Good morning, good afternoon, everyone. Welcome to this DCB Academy lesson on therapies that reduce vulnerable plaques, which will be presented by Dr. Giovanni from Spain. Please, Dr. Giovanni.
Okay, thank you. Thank you very much for the introduction. I'm pleased to discuss with you current technologies, pharmacological and non-pharmacological strategies to treat atherosclerotic vulnerable plaque. So we will try to discuss the topic, and at the end also discuss if it really matters to treat atherosclerotic vulnerable plaque. So when we talk about vulnerable plaque, we basically define an anatomical atherosclerotic vulnerable plaque. There is nothing other than a thin cap fibroateroma. Thin cap fibroateroma characterized by a necrotic core. There is separated to the lumen by a thin rim of fibrous tissue. So when we talk about necrotic core, we define an lipidic plaque, defined as the presence of a lipid arch more than 90, or in some cases defined by more than 118 degrees, and a lipid core burden index more than 400. So it is a lipid plaque containing free and esterified cholesterol, and also dead and apoptotic macrophages, along with some tissue factors. It's important to consider the thin rim of fibrous tissues that separate this atherosclerotic plaque from the lumen, because it's one of the most important characteristics that has been considered and will be considered also in the current and future clinical trials. So the rim of tissue is defined thin if it's less than 55, or in some cases 65 micrometers, and often contains macro and micro calcification, and below of that inflammatory cells infiltrate. Some kinds of neoangiogenesis, intraplaque hemorrhage is also present, and with the definition of vulnerable plaque, we will see what really it means. Vulnerable plaque is present in the context of a small luminal area defined by a minimal lumen area less than 3.5 millimeters squared, and in the context of a large plaque burden defined as more than 70% of the plaque burden. So what about vulnerable plaque detection? I decided to put as my first slide the OCT because it's definitely the most used, even if it's not just the most sensible technique to detect vulnerable plaque. As you see at the left part of the screen, we see the lumen, the plaque, and this is visibly a lipid plaque. There is subtended by this thin rim of tissue that, as you can see, is different from the thickness of the other part. So we see a thin cap that is subtends a lipid plaque. And also in other view, we see the presence of microchannels in the intima, or we see that in the majority in a percentage of case, we can see that the vulnerable plaque can also be ruptured. Another important thing that has been considered also for treatment reason is the presence of macrophage. Macrophages are depicted as hyperechogenic structure, so highly yellow structure that it has like a shadow below them, and are contributors and main characteristics of the vulnerable plaque. Other techniques that has been investigated and that basically has defined the topic of vulnerable plaque has been the NIRC, the near infrared spectroscopy. And with regard to this technology, it's nice to share with you what does it mean to detect a vulnerable plaque by means of NIRC. So as you can see, this was a case of a patient that underwent stenting in the culprit lesion, but also his right coronary artery was. There were two findings of non-culprit lesion, like very stenosis segment, the non-culprit lesion number 1 and the non-culprit lesion number 2. As you can see, for the non-culprit lesion number 1 compared to the non-culprit lesion number 2, there is a very high content of lipid content that you can see in yellow, and the maximum lipid core burden index in the 4 millimeters of the evaluation was above 400. So it was 687 was what happened that at a follow-up at more than 3 years after that event, the patient was again evaluated for an acute coronary syndrome, and the culprit plaque this time was that one, the first that was depicted as with a high lipid content. So it was an atherosclerotic plaque. In this context, the co-registration with the IVUS showed us that the minimum lumen area of the non-culprit lesion was 3.8 millimeters squared, with a plaque burden of 80%. If we have analyzed two of the major invasive imaging technologies in the detection of vulnerable plaque, there are basically OCT and NIRS IVUS and IVUS. It has been known that there are other non-invasive techniques, as we see in this slide. I try to add a look to the CT scan. So basically, with regard to the vulnerable plaque characteristics, positive remodeling, a low CT attenuation plaque, napkin ring sign, and spotty calcification are the 4 main characteristics that define a vulnerable plaque. As you see for example, for the napkin ring sign, you see that the yellow ring depicts the lumen, and above that you see a low attenuation signal that is covered by a higher attenuation signal. Why CT is coming to be an more and more important technique to define a vulnerable plaque, because the concept of vulnerable plaques is progressively shifting to the concept of a vulnerable patient, and the CT in this context offer the opportunity not only to evaluate a vulnerable plaque and its characteristics, but also other things, as you see to the right part of the screen, the epicardial adipose tissue. The epicardial adipose tissue has been found to be a highly contributor to the vulnerability of the plaque. And in the low part of the right side of the slide, we see also a technique that is the fat attenuation index, that has been found to be another important contributor to the classification of high-risk plaque. Why we talk about vulnerable plaques? Basically, we talk about vulnerable plaques because when we have found those characteristics, the ones that we have described with the invasive and non-invasive imaging techniques, we have also found at the follow-up and the majority of the study that have investigated the natural history of the plaques, we have found that this particular characteristics are related to a higher incidence of adverse events, especially MACE, and among those, TLR, target lesion revascularization, spontaneous MI, and in some studies, cardiac death. So as you see in this Kaplan-Meier curves, for the patient that for the patient with a non-calculated lesion, the rate of MACE is quite high. And importantly, for the patient that this was a study coming from one of the first study conducted on vulnerable atherosclerotic plaque, the prospective absorbed, the patient with with at least one non-calculated lesion with a plaque burden more than 70% and a maximum lipid core burden index in the 4 millimeters more than 324, they had a more than double number of MACEs. So, with regard to the treatment of vulnerable plaques, basically, what observational and randomized clinical trial I'm trying to investigate in terms of treatment of the vulnerable plaque, we can divide two different pathways: the non-invasive strategies of systemic medical therapy and the invasive strategy of local preventive therapy. Here I'm trying to give a rapid look to the current tested strategies. With regard to the idea to treating vulnerable plaques, I would like to highlight that for non-invasive strategies of systemic medical therapy, you can intend that it's true that we have as a major focus like the vulnerable plaque, but it's not just the concept of eating the vulnerable plaque. So from this concept we obtain like information on the importance and on the objective and the aim to treat the vulnerable patient. And by treating the vulnerable patient, we have some good news with regard to the vulnerable plaques. In the last decade, treating vulnerable plaque has meant that using anti-lipid lowering therapy could have an impact. And the yellow
Giovanni, excuse me. Giovanni, you have 2 more minutes for the presentation.
Okay. So the yellow, the EasyFit, and the ESCORT trials trying to investigate the role of atorvastatin, rosuvastatin, epitavastatin in reducing the incidence of the vulnerable plaque, and this has been shown intended as in an increase in the fibrous cap thickness and in reduction of macrophage content. More importantly, other than the atorvastatin and the statins, an important result has been occurred by the use of PSK9 with the Huygens and the Pacman MI. Other studies have investigated the role of ezetimibe and omega-3 with no clear result. With regard to other pharmacological therapies, the colchicine has been shown in small trials, the positive effect on treating the vulnerable plaque with regard to the cap thickness. And also there is some studies that are trying to see in GLP-1 receptor agonist some interesting new therapies. So when we go to treating vulnerable plaque with regard to stenting, a few studies like the Prospect, Absorb, and the Prevent have showed that treating locally the vulnerable plaque may result in a reduction of hard endpoints, but those results are not generalizable. What I would like to say as a finish, just to finish and just to recap, there has been also a study that has investigated the role of treating a vulnerable plaque by means of paclitaxel coated balloon. This was the debut LRP study. Basically, there were patients that were randomized to undergo IVUS NIRS of the three vessels, and if one of the main characteristics of a vulnerable plaque were found, those patients underwent paclitaxel eluting drug coated balloon treatment, and what appeared, and that a total of 17 patients at 9 months resulted in a significantly decrease of the maximum lipid core burden index, and with an important change from the baseline. Other techniques has been investigated, as the cryotherapy in animal models, and so if we think other pharmacological or other preventive strategies intended to stent a vulnerable plaque, that it could mean to seal the vulnerable plaque and a little bit change the natural history, we then have a final result, or that it can say something about, especially about the local treatment. So with regard to the stenting or other local strategies, we don't have any kind of certainty. With regard to the pharmacological strategies, the pharmacological strategies are can be thought in the context of treating vulnerable patient and not the vulnerable lesion. Okay, thank you.
Thank you, Giovanni.
Thank you.
Thank you for this. Yeah.
Thank you, Giovanni.
I try to be a bit fast in the last part of the presentation. So if you have any question, we can.
Yeah. So it's very important to be within the time allocated, which is strictly 15 minutes, because I want to leave also some time for the discussion. But yeah, you did a very good job in depicting in 15 minutes the spectrum of vulnerable plaques, which actually is still a highly debatable topic, not only related to the fact that, as you said, we don't know the exact optimal therapy, but also because it's difficult to understand, according to the information that we have from several studies, which is the exact pattern. Probably it does not exist an exact pattern for the vulnerable plaque. This was one of the major criticism for the PREVENT trial that we discussed also in our state-of-the-art review, which is, it's quite easy to keep the limits of a vulnerable plaque either wide or strict, and so you can have a lot of different situations, either clinically and also from the lesion standpoint. So not having clear rules is difficult to find an appropriate treatment for the patient or for the plaque or for the lesion. It's very difficult. So this is currently, I think, the most important challenge for vulnerable plaque, which is, what is a vulnerable plaque? Okay, you were mentioning 55 micron of strut thickness. That's just one of the parameters, 65. In earlier studies, it was 70. I remember at least one study where this cutoff was 75. Okay, and this is just one parameter for protecting the lipid-rich core plaque. And then we have the eruptive calcified nodules. We have discussed with Akiko Mehara about this completely different pattern. So different risk factors, different clinical outcome. And what about the, I would say also, to be a little bit more provocative, the non-eruptive calcified nodule? That's still a very complex lesion. If you put a stent there without having addressed this disease, you probably create a new vulnerable patient, which is prone to higher risk of restenosis, thrombosis, and all of that. So still, I think there is a huge work in progress for this milieu, but it's, I would say, also one of the most fascinating one in interventional cardiology so far.
Yes, Prof. This is why I try to give a resume to the about the current technologies that we have to detect vulnerable plaque, that basically are a lot of techniques, but they are not standardized. So if you decide to define a vulnerable plaque by means of the thin cap fibroteroma, it's one thing, but it's completely different from defining the NIRS based the characters, no, and also it's important. I think that we are carrying out at my center we are carrying out the vulnerable trial and the combined intervene. The combined intervene, there are basically two trials that are trying to treat by means of stenting vulnerable plaques. And what I see is that there is a lot of inter-individual variability in the definition of the vulnerable plaque, because I can measure 60 microns, you can measure 75, and how can 15 microns can...
So it's also a matter of how you do the core lab analysis of that OCT. Yes, it's really too open.
How can it be translated in the clinical practice? If we imagine every center, not all centers are like extremely good with trained to the OCT analysis. So, and this is important. I think that the idea provided by for the first time by Valentin Fuster about the idea to treat a vulnerable patient, that could be really the target, because we also included in the vulnerable plaque definition the plaque burden, but the plaque burden doesn't refer just to the single plaque, but to the amount of plaque independently from its composition in the entire vessel. Is the percentage of the plaque compared to the vessel.
Yeah,
so,
but okay, that's fine. We treat the vulnerable patient, but there is a big caveat in that, because if you detect a vulnerable plaque with any imaging, it's fine, because you can detect it also preventively before the event. If you treat the vulnerable patient, it can be, in many cases, too late, because the patient has already come to the hospital with an event. So this is the problem. So you can treat the vulnerable patient, but that could be too late for preventing events and also to protect him.
Yes.
Any other question?
My question is, in general, for Giovanni, for you, for Professor Cortese, when would you treat now, with the evidence that we have now, a vulnerable plaque? And what strategy would you prefer in general?
Oh, okay. I think that actually, if I have the opportunity to make an OCT analysis on a patient based on the angiographic occurrence of the angiographic occurrence of a multivessel disease, basically I would perform OCT analysis just in the context of ACS. So ACS patient, multivessel disease, and with the idea to perform OCT in my center if some of the coronary angiographic characteristics don't make feel like happy with the angiographic characterization. But once I've done my OCT pullback, I don't treat currently in my current practice just a vulnerable plaque. If I see that there is plaque rupture, if I see there is plaque erosion with a thrombus, then I would treat. So at this point, other than preventive stenting in vulnerable lesion, as defined by the current knowledge, I would prefer medical treatment. That it means alirocumab, evolocumab, and high statin therapy, and also the idea to consider GLP-1 agonist receptors in patients that really could have a result from that, because I believe that the result of the SELECT trial were very eloquent with regard to the reduction of the cardiovascular events of patients independently from the presence of diabetes. Yes.
Thank you, Joe. Thank you. Clear. So actually, medical therapy for vulnerable plaques, if you have a patient with acute coronary syndrome, you don't find a complete lesion, you stand only if you find, for example, a plaque with clear characteristics of, we can say malignant, erosion or...
Yes.
Exactly. Or plaque rupture, yeah. Right.
Yes, if it's not severe. Yesterday, I have a patient with an end-stage ACS, non-ST elevation. We stented the LAD, and there was a bad plaque in the proximal right coronary artery. We performed an OCT, and we saw that it was a plaque erosion with a some thrombus on that. So. And there was some plaque hemorrhage. So based on that, we decided to stent the patient to perform stenting. But I would never stent the patient if I have just found just a lipid core burden and a thin fibrous gap. No, that's my idea and our current practice.
Nice. Thank you.
Any other question for Giovanni?
Thank you, Giovanni. Just a question. And what's your opinion about including also abnormal endothelial stress in this context, as the prospect study indicated that the combination of abnormal endothelial stress and vulnerable plaques increased a lot the positive predictive value of this model. It could be feasible in the future in clinical practice, in your opinion?
Yeah, Filippo, thank you for the question. There are many studies that have studied and have evaluated the value of endothelial shear stress and also the position of the lesion inside of the coronary tree that it can have based on that a different outcome. I think that if we consider a normal clinical practice, it won't be feasible, and that will be impossible to include it in our daily clinical practice. As it is the CMR, or the pre-coronary angiography, perform the CMR before coronary angiography in presumptive myopia patients. So I think that actually it could be just a research tool, and it will be so for the next year. And I think that the only idea could be a non-invasive strategy. So it could be a software included in the CT analysis, but together included in a big model that could depict the vulnerable plaque. Yes, this is my idea, my current idea. Yeah.
Thank you, Giovanni.
All right. Thanks a lot. Giovanni.
Yeah.
Please, Filippo.
No, I agree with Giovanni. The idea of including this parameter in non-invasive techniques could be very appealing in the future. But
yes.
Currently these techniques have a lot of limitations. Yesterday I did a patient with a CT scan with a moderately calcific lesion in the middle AD and not significant lesion in the distal left main, sort of 30% distal left main and 50 to 75% calcific in the middle AD. So we have a very strong program here of CT scan. So they use HeartFlow, they did FFR. FFR was positive. FFR was positive with a point, let me see, 74. Yeah. So non-invasive FFR here with HeartFlow. So we brought the patient to the lab and we did angiography, which was, I was of course ready to stand the patient or to do imaging. But, you know, angiographically, the lesion was 25, 30%. Very, very smooth borders, no signs of any plaque rupture or any plaque complexity. So I didn't do any imaging. Patient was asymptomatic, so I stopped it. So all of these non-invasive measures, also in highly experienced centers here, we have done in 7-8 years, 80,000 calcium score, and many of these patients underwent CT scan afterwards. So also here, there are many limitations for these techniques so far.
Yes. No, what I think that is important. There is a technique, Filippo. With regard to the functional assessment, we have talked about the shear stress and stuff like that, and also to integrate the comment of Professor Cortese. There is a small study that is from the PTRA project from De Bruyn and Carlos Collet that found that there is a relation in between the vulnerable plaque and some functional assessment. So especially for FFR less than 0.70, and also with the result of the pullback, the pressure pullback gradient. I think that it's early to say something. I think that something that I didn't have in the slide, but that could have a good diagnostic accrual could be the PET, the PAT. They are not finding a good results with the sum of the tracers if they use the 18 fluoro marked glucose. It is difficult to perform the analysis, but I think that some receptor they are investigating on some somatostatin T receptor that are on macrophage. Is the tracer is called the dotatate and the other tracers. I think that through PAT, through PET, it could be easier to really depict and find a really inflamed and burning plaque, and this could help more, I think, than the functional assessment. But yeah. we are really at an embryonic level. We are as
work in progress.
From my point of view, the majority of the cons, they say, okay, you are stenting a vulnerable plaque, but if you stent a plaque, you need to say that there is a target lesion revascularization. So you cannot consider the optical medical therapy and the stenting. You have to consider the baseline stenting as an event, and if you then calculate what will happen in the future, you need to consider the periprocedural myocardial infarction as well the possible future spontaneous MI. And what we know is that in the context of 100 plaques, 95 won't have nothing to say in the future. Yeah. So what we could save is a 5% event. How this event can have an impact, a clinical impact, we really don't know, because there are many plaques that are ruptured and then that heal without having a clinical significance. So
yeah. Okay. Thank you. Thanks a lot. Thanks.